morning, everyone. Thank you so much for joining us. Welcome to those people that got here after we got started. My name is Nyari Sirewa. I'm Patient and Professional Programs Coordinator. Welcome to the conference session titled Advances in High-Risk MDS. As we get started, MDS would like to thank the generosity of our corporate sponsors. At the diamond level, we have Alexion and Novartis. At the gold level, we have Apellis, Genentech, and as well as the generous support of our patients, families, and caregivers for supporting our conference today. Immediately following the session today, there'll be a question and answer session. When we're asking questions, we ask that you say them out loud so that everyone in the room can hear them. And I also ask that you do not share any private health information in your question, as our speaker today cannot speak directly to your health situation. Today's specialist is Dr. Zara Pakbaz. She is a board-certified UCI health hematologist who specializes in non-cancer blood disorders. Her clinical interests include thalassemia, sickle cell, red blood cells, iron overload, clotting disorders, and disorders of high or low counts of platelets or white or red blood cells. She's passionate about delivering patient-centered care to people with blood disorders, and she works collaboratively with primary health care physicians and other specialists. With that said, please help me welcome Dr.
Thank you. Good morning. Okay, it's a pleasure being here with all of you. Today we're going to talk about new data, exciting data that everybody's talking about, and doctors are very excited. And so there are three abstracts that is from ASH, American Society of Hematology, that was presented in December, which seems like to be practice changing. So that's why I picked these three abstracts. And also limitation in time doesn't allow us to go over more other data, but I think these are very important abstracts. So one is about using venetoclax and azacitidine for treatment of high-risk MDS. So this was a multi-center study. So the logic about this study is that azacitidine has been shown to be effective in high-risk MDS, in increasing the survival. However, we still want to improve more, as is not enough. So on the other side, venetoclax, which is a potent BCL2 inhibitor, has been shown to work in malignancies, myeloid malignancies like AML. So then there was a phase 1 study that said, okay, what about we use the venetoclax with azacitidine and see what does it do in high-risk MDS? Because kind of biology-wise, it's kind of AML is kind of progression of MDS, high-risk MDS. So it should be some effect by logic. So based on that phase 1 study, they ended up with coming up with the dosing of venetoclax, and they published the data in New England Journal of Medicine. So then, based on that dosing that came up from the phase 1 study, they developed a phase 2 study. So today we're going to talk about the phase 2 study. So this is a treatment that they were using in patients who did not have treatment-related MDS. This is MDS de novo, meaning from the beginning it was MDS. It wasn't like some other disease progressing or people developing MDS because of chemotherapy. Now, and then also they were supposed to have IPSS or more than 3, so meaning kind of higher risk MDS, ECOG less than 2, and then ECOG is a way of saying, oh, this patient has a good functional, or they are a little bit frail, or they are very frail. So the higher the number would be more frail, and the functionality be less. Now, bone marrow blast less than 20%. And so based on this, the dosing for venetoclax came up to be 400 milligram daily from day 1 to 14. But in AML, they use it in more days. and azacitidine, the same standard dose of azacitidine. The primary objective was to look at complete remission rate, and then there were some other secondary findings. Like you want to know what happens in remission in bone marrow, response in bone marrow, or what was the overall response rate, or how was the hematological improvement, and then if hematologically patients improve, like blood counts, right? So you have change in bone marrow and you also have change in blood counts. You should translate to change in blood counts, otherwise it's not going to benefit the patient. Or time to treatment, next treatment after this treatment, or time to progression to AML. And then overall survival. So those were all the secondary goals that they were hoping to get out of this study. And then the response was used. How to measure the response was based on International Working Group 2006 criteria. And the one thing that was specifically in this protocol was that everybody would get prophylactic antibiotics in cycle 1, and in the rest of cycles, if they had grade 3 or more neutropenia, then they would get prophylactic antibiotics as well. So basically, severe neutropenia that would be life-threatening. Those patients also would get antibiotics. And anyone who got one dose in the trial, one cycle basically, or one dose, was being included in the data analysis. And then patients were followed for about 36 months. So that's how long the data was. So this is good for 36 months. Now, these are the characteristics of the patients. So 107 patients were participating in the study. Median age was 68. But there were patients anywhere from 26-year-old to 87-year-old. And the main thing here is that in this trial, everybody had, majority of patients were ECOG 0 or ECOG 1. So these are patients who are transplant eligible or chemotherapy eligible. So they were better functioning patients. And the blast numbers, majority of patients had more than 5% blast. Blast in bone marrow was around 11% in median percentage, but it was anywhere between 1% to 19.5. The IPSSR, as we said, it was supposed to be more than 3, so higher risk patients. And also baseline mutation ASLXL1 and TP53, that these are like poor prognosis mutations. About 34% had ASXL1 and then 23% had TP53. So these are the efficacy. So we were going to review efficacy and safety. So in terms of efficacy, they divided the response to complete response, marrow complete response, and then overall response rate, and modified overall response rate. So the modified overall response rate includes complete response, partial response, and also marrow complete response, which was 86% of participants achieved modified overall response rate of 86%. I'm sorry, 80%. And then hematological improvement was 37% in patients who had marrow complete response. So meaning in those who there was response in bone marrow, improvement in bone marrow, they also had improvement in the blood counts. Now, no matter which cell count you were looking at, platelets or RBC or both, there was more than 50% improvement in blood counts of platelet becoming transfusion independent. Now, overall survival was 26%. Time to complete response was 2 months, basically 2.8 like busy cycles, because cycles were 28 days. And median duration of this complete response was 16 months. Median time to AML transformation was about 6 months. Median time to needing treatment was about 7 months. Time to transplant, needing transplant was 4.8 months. Relatively, and I put all these abbreviation so that in case you forgot what is what, you can look at the bottom of the table. So I'm gonna pause a second, giving you the chance to look at the table. Okay. All right, so I'm gonna move forward. All right. So now a couple of additional outcomes that I think is important for when we have an MDS, we want to know, right? So estimated 12 months overall survival was 72%. Estimated 24 months overall survival was 51%. And median overall survival for complete response was not reached. Now, 57% of patients had subsequent treatment, and 39% had transplant of this 57%. Median time to transplant, as I said, was 4.8 months, but it was anywhere between 1 month to 16 months. Now, I think the important thing here also is that uh, among patients who received transplant after the study, 17 of these patients did not qualify for transplant prior. They were not transplant eligible. But then after the study, they were transplant eligible. And median maximal duration of transfusion independent was about between 5 to 6 months, anywhere from, and the range was from 2 months to 50 months. But because the median is more like 5 months, so it was more toward the shorter time of 5 months. Now, post baseline overall hematologic improvement about 50%. Now, what about toxicity and adverse events? Right, this we want to see if it's safe or not. So, as you saw, these were kind of high functional patients, and so every patient experienced at least one treatment, adverse event that was because of the treatment. And 94% had grade 3 or more, meaning severe cytopenias or something severe that needed intervention. Now, severe adverse events, which was occurred in 68% of patients, also now, common treatment-related therapy complications was constipation, nausea, diarrhea, vomiting, and low potassium hyperkalemia. So at least more than 40% of people were experiencing some sort of the most common types of uh, adverse events. Now, grade 3 or more adverse events related to treatment that was more than in more than 20% of patients was cytopenias, which we always get in chemotherapy. So for between 40 to 30% of patients had some sort of low count, such as neutropenia, low neutrophils, low uh, platelets, fever. So those were quite common. And infection was in 57% of patients, and severe infection was about 40%. So it was kind of tough treatment, and that's why it was more for patients who are transplant eligible or chemotherapy eligible. There was 55%, unfortunately, patients passed away, but most of the that was from progression of the disease, not the treatment itself. From treatment, adverse events was 6% of patients passed away. Now, 60-day mortality, that is a landmark for all the trials we look at, it was only 6%. So pretty, let me see. So then in conclusion is that the 14-day venetoclax of 40 milligram a day and plus as a side income was well tolerated and good effectiveness, more than 80% overall modified overall response rate. Also, hematologic response was in almost 50% of patients. But remembering these are more healthy patients, like in terms of ECOG score of most of them were 0 or 1. And we said lower the score, higher functionality, more they would be more tolerating aggressive treatment. Now, there is a phase 3 Verona trial right now going on, and in a larger number of patients to confirm the findings in this phase 2 trial, which was monitoring patients for about 31 months. So this was for uh, good functioning. Now, what about patients who have higher ECOG, right? Frail patients who cannot tolerate this severe treatment, right? This aggressive treatment. Well, there was another abstract here that was looking at another compound in adult patients that haven't been treated um, um, for severe, like advanced MDS. So this product is called IMM01. So IMM01 is a SIRPA fusion protein. Now, what does that mean? What does it do? Well, it's an anti-tumor activities. There is in two ways it works in MDS. One is it changes the signal. As you know how tumor cells escape. So that's how they become malignant, right? They escape the mechanism of that. Uh, uh, After a while, cell is supposed to die, right? So in our body, we have a mechanism that eliminates older sick cells. But in malignancies, that signal, because of the change in the characteristics of the cells, then they become, like long lasting. They don't die, basically, because they escape that eat me signal that becomes on the surface of the cells, and then cells that their job is to eat these tumor cells, they don't recognize them. So then these cells continue growing and then they don't die. So what this product does changes this from don't eat me to eat me, basically, on the tumor cells, right? And they create a antibody dependent cellular phagocytosis. So it induces the phagocytes to be able to kill these tumor cells. Now, the other way, also another mechanism, is that it induces long-lasting tumor-specific T cell immune response. What does it mean? So we have the cells they call macrophages, right? These macrophages' job is to, take the part of these. They take the cell, the bad cells, and then they digest them, and then they put part of these digested cells on top of them, macrophages. Then they go and then say hello to T cells that are one of our important immune system cells. They say, oh, get to know this cell. If you found this is bad. You have to kill it, right? So this way, our immune system recognizes these cells and then kills them. But as I said, they are already hiding, right? So this product changes this and helps T cells recognize the tumor cells. So two mechanisms. Now that we know what is this product, they developed a phase. This is the data from China. It's a multi-center study in China. It's a phase 2 study, and about 50 patients were enrolled in this study. So they added this product, IMM01, to azacitidine, then as a first-line treatment for untreated high-risk MDS individuals. So it was in adults, and again, IPSS ARA more than 3.5, meaning high-risk MDS. And these are in patients who actually weren't transplant or aggressive chemotherapy candidates. So, and so this is a IV infusion. So the product is an infusion and is a weekly infusion in addition to azacitidine. Now, so the outcome, the adverse events was also reported. Efficacy was based on international work with 2006 criteria for MDS. So this is the patient criteria. So as you saw, again, median age 64, and age was anywhere between 30 to 83. About 70% of patients were male. Now, here you see patients had ECOG score of 1 and 2. So that means that they may not be a good candidate for transplant or for aggressive chemotherapy that we use in high-risk MDS as a standard of care. The other thing was that, as you see, These were 46% of patients were high risk MDS, 29% were very high risk MDS. And there was 38% of patients had 38% had MDS with excess blast 1, meaning they had a blast between 5% to 10%. And another 35%, they had blast between 10% and 20%. And then these are the white blood cell, the cell count. The baseline cell count, like neutrophil was, median neutrophil count was 800, median platelet count was 39,000, and hemoglobin of 6.9. So they were quite low counts. Now, as I said, there was 54 patients enrolled. Because this is a preliminary data and the trial is still ongoing, so we have the data for about 6 months of data, anywhere between 6 to 7.9. So there was, for patients who were under treatment for more than 4 months, there was 22 patients that they were able to analyze the data. In these patients, overall response rate was 81%, so very impressive. Complete remission, complete response was 36%. Marrow response with improvement in blood count was 22%. And then hematological response only was 9%. Bone marrow only response was 13%. So in patients who received more than 6 months of treatment, 17 patients were analyzable based on more than 6 months. Again, very impressive overall response rate of 88%. And I'm going to let you read the rest because it's not much difference. Now, they also had these mutations that these are not really fun mutations, but during the trial, it was seen that the frequency of these mutations also went down. These are mutations that were causing this right high risk MDS. So it means it affects the mutations, actually kind of reverses the mutation. Okay, now what about toxicity? All right, so these are the most frequent treatment-related toxicities, more than 20%. As you see, vomiting, high temperature, infusion-related reaction, constipation, nausea, infection, only 20%. So prior study, we saw that infection was 50 something percent, right? 57%. Although we cannot head to head compare the data because those are very different patient population. You always have to see what the patient population is. But so this was a really, mild treatment for patients who are not in a good shape. Now, they still had high rates of cytopenias, right? So like 66% low white count, 70% low platelet count, or 80%. Yeah. So still we had low counts as a consequence of the treatment. Other adverse events, grade 3 or more treatment-related adverse event still was related to cytopenias, and infection was only 16%. In terms of somebody getting infection, needing antibiotics, and getting admitted to hospital, like that. That's what grade 3 means, grade 3 or more. Now, and then they said actually that the author said that this is consistent with side effects patients get in China from azathioprine. Azacitidine. Right. So they didn't consider this related to the new treatment that they added to azacitidine. And they were not using the low priming dose, meaning that it would cause grade 3 or more hemolysis. Hemolysis, as you know, is a red cell breakdown that causes drop in hemoglobin. So in conclusion, it seems like this IMM01 with low dose priming, without low dose priming, when it's added to azacitidine, was well tolerated and exciting efficacy. Like overall rate response was 80% or more. So So that's for frail patients. Now, what do we do if these patients relapse or didn't respond to these azacitidine-based therapies? So we are talking about azacitidine and then adding things. So that's why we call it azacitidine-based therapy. So what do we do for those? Is there anything new for that type of patients? Well, now we do. So this is a smaller, much smaller study. It's a single site. It's out of MD Anderson trial, which is a phase 2, and it's for vibecotamab, which is a bispecific CD3 CD123 T cell engaging. So BITE, you might heard of BITE therapy. So this is a BITE therapy. And this was in patients who already had treatments and they either didn't respond or they relapsed. So what is this compound? So and then why are we using? What is the logic? So basically, these are high. There is high expression of CD123 on leukemic cells, and it has been shown that these then because they are and then these fabricatamab also works on CD3 and CD123. So it's a biospecific, means affects on two markers, right? So, and it has been shown that in AML patients who have low blast count, it kind of works. It has some effectiveness. So then they said, why don't we try this in MDS patients, right? In high risk MDS, they also have, relatively low blast counts. So let's try it in these patients. So in this trial, there was two arms. There was 23 adults, and it was two arm. One arm was leukemia patients, the other arm was MDS or CMML patients, and they were higher risk. And they enrolled patients who were already failed the azacitidine therapy based chemotherapy. And also the expression of the CD123 should have been more than 20% in the abnormal white blood cell, stem cells or blast. So this one also is an IV therapy, and it would be first they would give some ramp up. So ramp up means they every certain days they increase the dose by some certain by some certain amount, and then weekly. So first week was like kind of multiple doses, and then weekly in addition to other cycles. And they were looking for 4 cycles only. What happens in these 4 cycles? And then each cycle was 28 days because that's how we use the other cycle. Now, the primary endpoint was, summing up all the responses, complete response, marrow complete response, partial response, and hematological improvement, and also clinical benefit. Also, the primary endpoint, and then also in AML, also they were looking at MRD negativity, meaning minimal residual disease. So the AML patients who were included were those who their bone marrow looked okay. They couldn't see blast, but then when they would do flow cytometry, that is specifically picks these cells in the blood, which is more sensitive way than looking at visually. They still had they wanted to see if these cells go away. So I'm not going to talk about much about, I'm not going to go through the numbers for AML because today we are talking about MDS, and I don't have much time left. So very quickly, so there was 11 patients with MDS. Out of these 23 patients, 11 was MDS or CML. 9 of them was MDS. So majority of these 11 patients had MDS, and they actually had some of them had more than 3 treatments. 8 of them already had the venetoclax that I talked to you about in the initial abstract. And also even 2 had transplanted. They had transplant. So these are tough cases, right? So, and then there was cytogenetics, bad cytogenetics like monosomy 5, monosomy 7, or diploid, and other. And then kind of like high risk mutations such as intermediate high based on IPSS. And then you can see in the lower row all the mutations that was involved in this in these patients. So that's the age range was 77. So these are relatively higher age than compared to the previous two trials, between 56 to 83. So the third column is the AML patients, but I'm not going to go through that. Okay, so now the response. Well, this was also quite good response. So based on International Working Group 2006, you can see the top responses, like 6 patients had complete marrow response. 1 patient had improvement in the hematological improvement. 1 patient had a stable disease, so it didn't progress during this time. So it's a short time, right? And also, unfortunately, 1 patient passed away, and then 2 progressed. But if you look at it as based on International Working Group 2023, and look only in MDS patients, it was even better results. Like complete response was 5 out of 9, no response 1 out of 9, progression was 2, and early death was 1. So, and then what was going on with the that CD123 that we are targeting, right? So those who were responders, actually they had 59% versus non-responders had 79%, right? So there was no correlation between response and these and like the frequency of how much expression was there. So that was the response in this trial. So again, it was well tolerated. This is the adverse event. Only 10 patients had infusion-related reactions, and 1 patient had grade 3, so more severe. So it was all the side effects was related to infusion, which was still not a severe reaction to the product, right? So it was only grade 2. 44% of patients had grade 2, and only 1 patient, which is 4%, the grade 2, which is more severe, needing kind of hospitalization or interaction. So, and then there was no myelosuppression, so minimal. They didn't see any myelosuppression. So this is consistent with other trials that they had done before with barbecudomab. So then, because there is no myelosuppression, it makes sense to add this to azacitidine, right? Very well tolerated, 64% response rate in MDS, 25% in AML with minimal residual disease, and so then seems like this works even in patients who had transplant and relapse, or patients who had prophylaxis treatment already. So if somebody relapsed the other treatments, we have some hope, right? But this is a small, only in 23 patients. So a bigger trial is required to, confirm all these findings. Thank you. Any questions?
We do have questions that were turned in by patients who are not able to make it, but will be watching online.
Okay.
The first question is intermediate MDS treated as low-risk MDS or high-risk MDS?
So there were intermediate patients in this trial. So yeah, they are treated in part of high-risk patients. And I didn't talk about intermediate because the numbers are smaller, but I can go back to the numbers if you want. So let's see here. Okay. Here they don't talk about it. It's more of the severe cases, right? Now in this trial, as you see, there was intermediate risk. I don't have a pointer, but here above these, the red dot, it's a 24% intermediate. So that's a good number, right? 13 patients out of 54. So that was that trial, the IMMM0. And then in the first one, the venetoclax one, let me see. Right. Did I share this screen? I think I came out. Yeah. Okay. In this one, you had intermediate 13%, right? So yeah. All right. So probably the low risk ones are the ones that they were severe or something that or borderline. They included in the trial.
And then the next question was asking about whether high-risk MDS can transform to AML and then back to high-risk MDS. Is that possible?
I don't think so, no. You move forward.
And then with the new IPSSM system, do patients need to be recategorized into?
Right. So ITSM came after these trials were going on, and I think they didn't want to kind of affect it. But yes, so right now, I guess everybody goes back and say, "Oh, let me see what's your ITSM," right? But it's a new categorizing. So yeah. So that was actually something I was thinking that maybe these can change. The outcomes would be changed if they change the categorization. Go look back and see. I'm pretty sure they're gonna do that at some point after the trial. Yeah.
And then my final question was asking whether you think that combination therapies would be best for treating MDS, high-risk MDS.
Right. So, as of course, if you don't have any choice, then you have to add it. And now this was actually in untreated patients, the first two abstracts. So they're trying to do something that, because single therapy, it works, but it's not optimal. So we want to increase the overall survival and response as much as we can, right? So if a patient tolerates the new treatment combination, you would want to do that, right? Because you get a better response. But it all depends on, okay, what are the categories of patients that you are including in the trial or in the treatment? It's all individualized. I think that's a discussion patient by patient, how each patient is different.
Any more questions in the room? Sure. Thank you so much, Dr. Pavlovans, for sharing.